Good morning, everybody.
Good morning.
Morning. Today we are talking about stupor and coma specifically, but we'll talk a little bit about mentation and then diving a little bit into seizures based on the kind of clinical presentation of seizures, not too much on the kind of etiopathogenesis and pathophysiology of seizures. But if anybody wants to do a deep dive, we can definitely expand, just ask questions. And I'll probably say, let me Google that quickly before I answer it. But we'll see how we go. Did anybody read the Edinger chapters?
Yep.
Nice work, Natalia. Are you studying?
Like they were not long though, so it was
No, they weren't.
easy. Yeah.
There's
Well,
not a lot of detail in there. Yeah. And this is, I think this section of Edinger, it's really hard not to just sort of be unsatisfied with the depth that you're getting. But really, this is a very clinical approach to problems that you're actually presented with rather than that diseases once you've made a diagnosis. So, yeah, as I said, happy to go a bit deeper if we need to, but or if you want to, but let's kind of stick to the content in the chapters initially. So let's start with mentation. What are the categories of mentation that we write in our histories in a physical exam?
Right alert,
Right alert and responsive.
Yeah.
Oh, sorry.
Okay. Yep. Good.
Non-responsive, perhaps.
or dull.
Dull. I think that's a good one. Yep. Yep. So I usually go BAR, QAR, and then dull, kind of as far as order of brain activity. And then what comes next?
Obtunded.
Good.
Comatose.
Stuporous.
Stuporous. Yep.
Stuporous next, and then comatose. So what is the difference between a stupor and a coma, technically?
So stupor is an arousable state, whereas in coma is non-arousable.
Good. And how are they, like if you say their name, are they rousable? What rouses them? The definition of stupor.
A pain stimuli.
Good. Okay. So that's a big difference as far as kind of obtunded. You can still get their attention with kind of stimulation, as opposed to stupor, where you have to actually hurt them to arouse them, to get their attention and make them move, basically. What are ways that you could, when you're doing your neuro exam and trying to assess mentation, can you use a toe pinch to determine whether they're stuporous?
Apparently not, because that's a spinal reflex.
Very good. So what response? So you can pinch their toe to get their attention. You can put a hemostat on their toe to get their attention. What signs do you need to see from them that will tell you that they're stuporous or that they're aroused by what you're doing? What's the normal response in a neuro exam to pinching the toe of a dog?
They withdraw the extremity.
Great. And what's the neurological loop that dictates that response?
It's just a spinal reflex.
Perfect. So is the brain involved?
No, not in that. No.
Good. Excellent. So if you're trying to differentiate between stupor and a coma, and you pinch their toe and they pull their leg back and you say, oh, good, they're responsive, it's not actually testing their brain or their level of consciousness or mentation. It's just testing that local sensory, spinal, and then motor pathway. So what other responses might you see when you pinch their toe that will test consciousness?
They turn around and try to bite you.
Yes, perfect. So behavioral responses, that's a very appropriate response to someone pinching you with hemostats. What else?
Blinking, something like that.
Sorry?
Blinking, like
Blinking, yeah. Yeah, they can sometimes wince, like you might see eye movement. So a dog that's not got motor function or been having seizures or something like that, they might not be able to turn around and bite you, but you might see some facial responses. You might hear some vocalizing, some subtle things. So sometimes it can be really subtle, but that still would classify as a stuporous state rather than a comatose state. Hi, the people that just joined. Josh, I thought you were still away.
No, back this week.
I would have loaded you up with some chapters.
Oh, sorry.
No, it's fine. It's just me being lazy. Oh my gosh, sorry, it's raining and my dog hasn't had a run this morning and she's gone mad. This is going to be a fun session. Okay. So the subject, for those that have just joined us, the subjects for today were stupor and coma and also seizures. And as I said, the chapters were pretty light on information-wise. So if you've got any specific questions, jump in and ask them. But we're really looking at the clinical presentation of altered mentation and seizures rather than the etiopathogenesis, pathophysiology and stuff like that. Okay. So we've kind of covered the difference between stupor and coma and differentiating clinically. I want to go through a neuro exam and helping to localize causes of coma and stupor or reduced mentation. There's one other mentation actually, sorry. We've covered BAR, QAR, DAL, obtunda, stuporous, comatose. There's actually one other which is not actually mentioned in every text or anything, but occasionally we see it. Does anyone know what that is? You can't get any worse than comatose.
Dead.
So it's at the other end of the scale.
Hyper.
Hyperexcitable? I don't know.
Yeah. So the word that is used most commonly is manic. So occasionally we have patients with, particularly with head injuries or post-ictal, they just vocalize nonstop. Hepatic encephalopathy dogs sometimes quite manic. Has anyone ever seen that? Dogs that will just pace and howl nonstop and just can't settle. Yeah, so that's one kind of comment on, like, they're not BAR, are they? They're manic would be the mentation that I put in my physical exam report. So if we let's talk a little bit about what dictates consciousness as far as kind of localizing a reduced mentation. Which parts of the brain, brainstem, neurological system are involved in the maintenance of consciousness?
Brain.
The brain? Forebrain?
Mhm.
Perfect. Yeah.
I think even brainstem to an extent, because
Good.
mentation changes would, like, you also have brainstem as a localization.
Yeah, absolutely.
Is,
No specific part of the brainstem?
is the thalamus involved?
Oh, good. Yes. Part, and I'm going to go into more detail about that. It's not one of the parts that maintains consciousness, but certainly transmits consciousness from the brain down into the brainstem. So it's a pathway that needs to be intact, but actually a thalamic injury in itself may not affect consciousness. Anyone know what part of the brainstem?
Ones? Is it like the medulla oblongata, that kind of area?
Yeah, good. Yeah, excellent. Pons and medulla. The name of the sort of the part that the series of neurons that pass through those areas, pons and medulla, is called the reticular activating system. Does anyone remember that?
Yeah.
It's an ascending tract through the upper brainstem that then transmits through the thalamus and up into the cerebral cortex. So the cerebral cortex is it kind of starts, how do we say, kind of maintains consciousness, whereas the reticular activating system refines it. And where a dog is manic, like that one, or comatose, the reticular activating system will kind of dampen that down a little bit. Just similar to how the cerebellum works with skeletal muscle movement. I'm gonna have to kick her out. Sorry. Go on. So they're the two main parts, and I guess the localization or their function is not that important. It's mainly that we know that we can have alteration, stupor, or coma developing from both forebrain disease as well as brainstem disease, either or both. So in that case, what sort should we go through a kind of bit of a differential? What might cause stupor or coma? Does anyone want to do that? Not really.
I guess intracranial or extracranial lesions,
Good.
and they can start narrowing everything down.
Yes, exactly. So let's talk about some extracranial things that might cause presentation with altered mentation.
Oh,
Neuro,
Did someone say neuro?
neuroglycopenia, I was gonna say.
Oh yeah, good. Exactly. So hypoglycemia, basically, would be the clinical presentation.
That's that more fancy name.
Yes, it's very, localized to the neurons. Excellent. So low glucose. What else? What about high glucose and also high glucose? Will we get altered mentation?
Yeah, because you will get cerebral edema from metaosmotic gradient, right? Or
Yeah, probably dehydration actually when they're really hypoglycemic.
or glucose toxicity. you
Yeah.
think?
Yeah. But yes, sorry, and it is neurotoxic, so we will get some cerebral edema eventually as well.
Is that when you'd be in a hyperosmolar
Yes,
situation?
exactly. Yeah. So it's actually usually when we drop the blood glucose that we get the cerebral edema occurring.
oh, yeah, right. So in other words, well, the same would apply if they're hypernatremic and you drop it too quickly.
Yes, exactly right. So what are the determinants of osmolality in the blood, the most significant determinants?
Sodium's the main one.
Yeah.
And then you've got potassium bicarbonate. Bicarbonate, what's the others? Chloride.
Yeah. So the chloride, potassium, bicarb are all very minor contributors. So by far and away the biggest one is sodium. Sodium, glucose, urea are the kind of three that we use in the equation to calculate osmolality. So increases in sodium and glucose will activate what in the brain or in the central nervous system?
Idiogenic osmoles.
Oh, so good, Jeff. And what that does is balances the osmolality in the CNS relative to the blood so that we don't get this sucking water out of the brain into the bloodstream. So then when you correct osmolality quite fast, what will happen to the water? If you've got higher osmolality in the CNS than in the bloodstream.
Sucked into the brain, into yeah.
Perfect. Yeah, exactly. So you get cerebral edema. Good. So that's one of the reactive causes or the extracranial causes of mentation changes. Other big ones like young dog, mildly elevated ALT, paces after eating.
High levels of ammonia, hepatic encephalopathy.
Hepatic encephalopathy. Good. Excellent. We're not going into the pathophysiology of that. Sorry. What about a patient with hypertension?
There is hypertensive encephalopathy.
Yeah, absolutely. Yeah. What else? What about, well, that's kind of more intracranial. What about SRMA, steroid responsive meningitis arteritis?
Or infectious disease.
Yeah. So vasculitis, increased vascular permeability, that's systemic, might contribute to cerebral edema formation. So say you've got, if you're kind of presented with a patient that's just presented stupor or comatose, no access to toxins. Toxins is another one we should put on our list, sorry. No access to toxins. And you do your neuro exam and there's lateralization of your findings. Is extracranial causes on your list still?
Yeah, there would be if it's spinal. It's a spinal lesion. Oh, sorry, what was the question again?
So if you've got
Yeah, it was,
patient presents with stupor and you're trying to differentiate from extracranial causes and intracranial causes on your neuro exam, and there's lateralization of signs.
No, I don't think no.
that'd be
I don't think.
So most of the time, extracranial causes of mentation changes, seizures, neurological disorders are quite generalized. So it's hard, they're not localizable. You might be able to localize them to the brain, but they're not going to be asymmetrical, because whatever that process is that's causing cerebral edema or inflammation in the brain is going to be throughout the brain. Make sense? So then let's talk about intracranial causes. Yes.
So hypertension, because if you have like a hemorrhagic infarct due to hypertension, that could be lateralized because it could just be one location, like one point part of the brain. Is it possible?
I would call that intracranial though.
Yeah, okay.
Yeah, rather than
Because-
extracranial,
yeah,
because
yeah,
it's a focal lesion.
Yeah.
It's hypertension, like hypertensive encephalopathy.
Yeah.
Okay, let's finish the extracranial and then I'm going to go into the mechanisms of cerebral edema, because I think that's a really interesting point that you've just raised.
Yeah.
Okay, intracranial, we know what's going to take up space in the brain and what's going to alter mentation, don't we?
Mm.
Do we need to do a damn it? Inflammatory, infectious, neoplastic,
vascular.
vascular, yeah, good. Anything else? Trauma, the big one. Okay, so let's.
Anomalous will be one for a like a young dog because your congenital hydrocephalus and things like that.
Yeah, good one. Yeah, exactly. And this is where I think it's nice to have a bit of a system of thinking about what might be causing cerebral edema, particularly in sort of young dogs and stuff. So if you've got changes in mentation, no lateralization of your neurological signs, and you're sort of thinking, okay, well, what are the causes of cerebral edema here? So that they divide cerebral edema into two types. There's cellular edema, where the actual neurons swell up. And then there's extracellular edema, and we'll talk about the mechanisms of that after the cellular. So we've talked about the differentials of cerebral edema in terms of like different like metabolic causes. So we talked about hypoglycemia or neuroglycopenia, as Natalia said. Will that cause a cellular edema or an extracellular edema?
Cellular.
Cellular.
Cellular, good. Yeah, exactly right. And what about a dog which has an intermittent arrhythmia and loses brain perfusion? Hypoxic injury to the brain.
I think cellular.
Cellular, good. And there's not that many other causes of cellular swelling apart from like ionic, like toxins, which will cause alterations or death of the NAK pumps and stuff that maintain the electrical gradient in the cell. So cellular edema is quite rare. Extracellular edema is quite common. Now let's talk about the different mechanisms. We've talked about edema, peripheral edema, and we know the mechanisms for that, don't we? So we've got increased hydrostatic pressure. Other ones, come on.
Oncotic pressure.
Increase oncotic pressure, yep. Or decrease oncotic pressure, yep.
vascular permeability.
Yes, good. And one more.
Incompetent venous valves can do it.
So I would still put that under hydrostatic pressure in the category. So that's one of the differentials within increased hydrostatic pressure.
Lymphatic venous obstruction.
Lymphatic, did you say? Yes, exactly right. So in the CNS, you kind of think about the same categories, but instead of lymphatic obstruction, what is the other kind of fluid drainage movement in the CNS?
CSF. So
CSF
like
is-
obstruction to flow of the CSF.
Exactly. Yeah. So we've got pretty much all the same differentials. We've got increased vascular permeability. Give me an example. Come on.
When the blood-brain barrier is disrupted, is that what you're getting at?
Yeah. I was thinking more
Any
of a disease
inflammation.
process.
Inflammation can cause that, like inflammatory diseases.
Absolutely. Yeah. Inflammatory diseases. So like GME and stuff like that. Tumors will cause inflammation, and we get that if you look at an MRI of a tumor. Often there's the tumor itself, and then there's a ring of edema around it. So localized edema due to increased vascular permeability. What might cause increased hydrostatic pressure in the brain?
Hypertension?
Chiari malformations and
Yep.
syrinxes.
Yeah. I'm going to call that increased CSF pressure. So
Oh, sorry, I meant the CSF. not the-
vascular hydrostatic pressure, I should have said, not so the difference, the way that they word it is when CSF is obstructed, it's interstitial hydrostatic or hydrocephalic pressure, as opposed to vascular hydrostatic pressure. Hydrocephalic and hydrostatic. So let's talk about vascular causes of cerebral edema. Sorry, hydrostatic causes.
Hypertension.
Hypertension, excellent. So that's the mechanism of hypertensive encephalopathy. CSF obstruction, Josh has kind of covered. The most common ones are Chiari and obstruction of CSF flow. And there's a lot of congenital forms of those, like cysts and things like that. Chiari, syringomyelia and things like that. And then what about in the older dogs that present with hydrocephalus? What's the usual cause of that?
A knee.
Yeah, as a mass obstructing the ventricle. Where does CSF flow from? From and to?
The fourth ventricle.
Mm-hmm.
Right.
Well, it goes. What direction does it flow? Does it go
Other
from the
direction.
spine up, or does it go from the brain down?
Brain down.
Brain down.
Absolutely perfect. So if you've got obstruction anywhere along the way from the lateral ventricles down to the brainstem or spinal cord, you can get a hydrocephalus developing. Okay, I think that's enough of that. What if we then look at intracranial pressure? What if we think of the skull as a box that's a closed box? What has to fit in that box?
All the brain tissue.
Brain tissue?
So
Yeah.
the blood,
Yep.
the CSF.
Perfect. So we've just talked about a lot of different mechanisms for increases in volumes in all of those things. What happens when you've got a full box and something increases its volume?
You get
Shoulder
increased
lines.
cranial pressure.
Yeah, so there's going to be increased pressure in the box, which is either going to reduce one of the other things, or the box is going to pop open, isn't it?
Yeah.
So I think most of us have seen patients where they've had central image, they've got a big mass, and they've had central imaging, and like their brain is just, there's like pressure necrosis of the area around the mass, and they've lost so much brain mass because something had to give. What happens when, say, a dog has acute onset cerebral edema? So we've got increase in brain tissue, basically. What's going to happen to the blood supply? The vessels trying to move through it.
There will be cerebral ischemia.
That's
Oh.
that's what's going to happen to the brain cells. What's going to happen to the vessels as it moves through an area with increased pressure on the outside of the vessel.
It gets squashed.
It's going to get squashed. Yeah. So we're going to get increased like hypertension within the brain, isn't it? So the pressure within those vessels is going to be higher. And then the brain's going to say, I need more blood. Crank the blood pressure, please, because I'm running out. And then what's going to happen to the on clinical exam? What might we see with a patient with acute increase in intracranial pressure and hypertension?
Vaguely mediated
Bradycardia.
bradycardia.
Bradycardia. Perfect. What's that reflex called?
Cushing's.
Cushing's reflex.
Yeah, great. Excellent. Has anyone seen it?
Once. Yeah.
Seen it.
Yes, it's definitely not present in all patients with increased intracranial pressure. It's much more consistent in acute onset intracranial pressure. So dogs with masses and things like that often don't get it. What happens? So you get hypertension to increase cerebral perfusion, but then the brain's not getting enough blood flow, not getting enough glucose, not getting enough oxygen. What's going to happen to our neurons?
Necrosis.
Yeah, absolutely. So we're going to start to get cell swelling and intracellular edema, as well as the extracellular edema that we've got. So this is the process. Once you've got increased intracranial pressure, it's going to make itself worse with that reduction in perfusion. So it's really important if you can identify Cushing's reflex to treat increased intracranial pressure straight away. What would you treat with?
Mannitol.
Yeah. Yeah, hypertonic saline is another option, but just straight in, don't wait if you're seeing a Cushing's reflex. Let's talk about neuro exam in these dogs. We talked about the symmetry. What else might you see in your neuro exam that would help you localize a cause of stupor or coma?
Cranial nerve deficits
Good.
help
Yeah.
cranial localization.
Yes. Yeah. And which cranial nerves are you particularly interested in?
Pretty much all of them, I guess. But yeah, you can do things like your menace to kind of check that pathway, your PLRs as well to check things like oculomotor as well. You can also look at things like tongue positioning to look for glossopharyngeal and facial nerve, if there's any, and trigeminal as well, for any kind of asymmetries or loss of sensation.
Yeah, good.
So all of those.
Yeah, so that's going to help you localize and lateralize as well, all of those ones. I want to go back to the eye movements. Why is the oculomotor nerve particularly important with stupor and the comatose patients?
We can localize to the brainstem because you're meant to have a normal physiological nystagmus. So you're kind of moving the dog's head, you should have a physiological nystagmus. And if that's absent, it makes it the brainstem.
Yep, absolutely. So even comatose patients who don't have a brainstem injury, so comatose patients who have coma induced, for example, like an anesthetized patient, should have a functional oculomotor reflex, so functional physiologic nystagmus. If you've got if you don't get physiologic nystagmus, it localizes to the brainstem. So cranial nerve 3, which is the oculomotor nerve, which dictates those eye movements, sits right next to that reticular activating system that we talked about. So they're really close together. So it's very hard to get an injury of the reticular activating system without suppression of the cranial nerve 3. What about Has anyone ever seen a exaggerated or increased oculomotor reflex? Or doll's eye reflex, I should say. Yeah. What sort of conditions would you see that in?
That was a cerebellar disease. Yeah.
Yeah, good. And diffuse forebrain disease sometimes as well. So hepatic encephalopathy is probably the one that we see that most commonly, where they've got really exaggerated eye movements. But that can also help you sort of, okay, well, we don't have a brainstem injury, we've got quite a diffuse cerebral injury. I'm going to definitely be looking for reactive causes of, or extracranial causes of altered mentation. So oculomotor, we've done kind of menace and stuff like that. Did you mention pupils? I might have missed it.
Yeah, he did.
Yes, good, thank you. Just testing. What are we looking for with the pupils?
Like meiosis, when you shine the light, like they should constrict.
They should constrict. Yeah, absolutely. I wish I had this open, but does anyone know about the Coma scale?
Or the Glasgow?
Modified. Yeah.
Yeah, modified Glasgow Coma scale. So we should probably be doing this with all of our patients that are presenting with reduced mentation. Because it helps us to prognosticate, to know whether to go ahead with treatment. And essentially it's got a score based on responsiveness, pupil, eye position, eye movements, and localization of the lesion. And if a high score is good, a low score is bad. And if your score is 8, then you have a 50-50 chance of survival. Small animals. This is specific for small animals, actually, I should say. So it's a nice thing to just do objective way of scoring the severity of neurological dysfunction, particularly when you haven't been able to identify the cause of it. So, you don't have to necessarily do an MRI. If their score is 2, you can probably say to people they've got really severe neurological injury and they've got a very poor prognosis.
Hey, Anna, I've heard some neurologists say that instead of like just one-off, ideally it's the trend. So if it's not changing, like within, and you should actually wait. I've heard 48 to 72 hours before. I mean, if client is willing, because at the end of the day, money dictates everything. But if the client is willing, you shouldn't make absolute judgments before 48 to 72 hour period.
Yeah.
Unless it's just deteriorating, then it's a different story. But if it's static, then there is it should be trends, not just one score.
Yeah, no, and that makes sense. Makes absolute sense. It does help you to monitor response to like mannitol and things like that.
Yeah.
So I think we see a clinical improvement with mannitol quite often. So it's an objective way of having different people assessing a patient and putting a number on it. Yeah, helpful tool, but yes, serial assessments are helpful for sure. Okay. Is there any, so as far as kind of neurological exam, we're looking for symmetry, we're looking for pupil changes, and we're looking for ocular movement changes. Is there any other things on your physical other than the neuro exam that you're very interested in looking at?
A retinal exam?
Retinal exam, very good. Yeah, absolutely. What might you see with cerebral increased intracranial pressure?
Oh, the optic disc.
Good.
Nice, and you can see the vessels sort of step off the disc.
Good.
Yeah, I picked up two brain tumors like that.
All right.
Wow.
Yeah,
Then CT them, and sure enough.
there it is.
So I think that the book set a name for that. It starts with P.
Papal edema?
Yes.
Yeah.
There you go. Thank you.
I know I couldn't identify it. I know what it's called.
Yeah. I've never seen it. I need to Google it.
I reckon I Google it every time I see a patient that I'm suspicious, and I have to say I've never been really convinced. I've seen a lot of dogs with increased intracranial pressure, but I find it a very insensitive test in my hands. I usually make Josh do the ocular exams.
Low sensitivity and high specificity.
Yes, yeah. I've lost my videos. Oh well. So yes, definitely fundus exam is important and can help you identify increased intracranial pressure. What about posture? Presumably your patient's not walking around if it's stuporous or comatose. But what might help you to localize injury or disease process based on posture?
Writing reflex, perhaps. That's isn't it?
Yeah, so they probably won't have a writing reflex if they're stuporous or comatose, I don't think, because that requires that brain interpretation and response.
Are you thinking about localization within the spinal cord, like C1, C6, and all of that?
No, because
Like the pistotonus.
yes,
Like the true classic decerebellate and decerebellate postures.
that's what I'm after. Thanks. Perfect. So what does a decerebrate posture look like?
That when I think both their forelimbs and hind limbs are in extensor rigidity.
Good.
And their neck is up.
Head up. Yeah, exactly.
Always have to do it.
Yes, a pistotonus.
Yeah.
Excellent. So decerebrate posture. What's the most dogs that are decerebrate are comatose. They're not responsive. What about decerebellate posture? How does that differ?
The pelvic limbs are flexed. That's the only difference. Otherwise, like the thoracic limbs have the same extensor rigidity, and your neck has that flexion, dorsiflexion.
Yeah, and the level of mentation change is often less severe than in decerebrate patients.
But isn't prognosis worse for decerebellate compared to decerebrate?
I don't know.
I was
I'd be
under the impression it
surprised.
is. I could be very wrong. I don't know where I got that from.
I'd be surprised if it is worse.
Because the brainstem is there. Like, wouldn't it make sense? Like, brainstem is such an important center.
Yes. So decerebellate posturing is, what's the most common presentation where we see decerebellate posturing?
MUO in severe cases, not always.
Yes, as a primary disease. I was thinking more like I can't think of how to word this question that's actually going to get the answer I want. So I'm just going to tell you. But I think when they're herniated is when we most commonly see decerebellate posturing. So it's usually secondary to other space occupying increased intracranial pressure processes. So often it is a little bit lateralized and there's other sort of neuroscience and stuff going on, or a long-term history or a short-term history or whatever. But it's when the cerebellum just pushes out from under that,
Cranial vault, like the vault, whatever. Cerebellar.
So then it does impact the brainstem because it puts a little bit of pressure on the brainstem, but it's usually the cause of the increased intracranial pressure is more the cause of their mentation change than what's happening on the brainstem with decerebellate posturing in that situation. Has anybody ever seen a dog that they know has herniated their brain?
Sorry, seen a dog with what? Sorry.
That they've documented that they've herniated their brain. This decerebellate kind of
I've seen. I mean, in brachycephalics, you often get a certain amount of extrusion of intracranial matter.
Yeah, true. Yeah, and cavies. It's wild. So what did Josh, you had one, I know that you've imaged and documented. What was the dog doing?
I think I saw this with you actually. It had an altered mentation.
It wasn't comatose, was it?
It wasn't comatose,
Right.
but then it suddenly became very severely unresponsive, and also had lost its physiological disableness as well.
Mm.
I think he's quickly CT'd it and herniated.
Mm. I once did an MRI on a dog. This is before your time, Josh, but I'd done a neuro exam on it, and it just had this really weird thing that every time I dorsiflex its head, its level of consciousness would drop. And it would get like flexion of the hind limbs and extension of the forelimbs, and it would kind of just fall to the side sort of thing. And it had metastatic hemangiosarcoma, so it had a left ventricular hemangiosarc with mets just all through its brain.
Oh,
And it had such severe increase in cranial pressure and quite intermittent, because it was obviously like bleeding and then clotting and then bleeding and then clotting kind of thing in the little brain. And it was so close to herniating that as soon as I kinked the CSF, and you know how they talk about not holding off the jugulars and stuff like that, it was like half herniating as I was examining it. So yeah, increasing that CSF drainage pressure in that dog was enough to sort of trigger that. And yeah, we got it to MRI to be able to kind of see it. But yeah, with head position changes, it made a big difference to this dog's intracranial pressure.
I saw it in an AA luxation as well. It was this dog that had I can't remember exactly, but it was very abnormal posturing with an AA luxation.
Really?
Yeah.
Yeah.
It went okay actually with
Yeah.
surgery.
How would that classify as?
I think I don't know if it didn't herniate its brain, sorry, but I think its brain stem got a bit squished.
Yeah, right. Interesting. With brainstem injuries, what might the breathing look like?
The term for it, cannot remember. Starts with K, something K.
There's a K one and there's a C one.
Kusma,
Both
something
Fs
like that. It's a rapid breathing, labored breathing.
Kussmaul breathing,
Mm-hmm.
which is a quite specific one, which is associated with severe metabolic acidosis, and it's big, deep breaths, like they're trying to breathe off all their CO2. That's quite specific, and I think, like, obviously extracranial. The one that I think we see more commonly is Cheyne-Stokes breathing, which is a cyclic hyperpnea and then apnea. And then they breathe fast, and then they stop breathing for a while. And then they breathe fast, and then they stop breathing for a while. And it looks a lot like Domitor breathing. I don't know if that's what Domitor breathing is, but it's an interesting parallel. And then what about when you've got a patient where you've just euthanized? What's that?
agonal breathing.
Agonal. Yes, exactly. So that's just the sort of brainstem signals, dysfunctional signals from the brainstem essentially, but that's very terminal. Okay, we've spent a lot of time on stupor and coma. Sorry. There's more to talk about than I thought.
Yeah, don't apologise. It was really interesting and useful.
Good.
Yeah.
You always say that, Jeff.
Because it's always true.
Thank you. So the other thing we're talking about today is seizures, and we're not really going to come back to mentation specifically. We're definitely going to come back to seizures and do it in a lot more detail. So first I want to just go back. We've got a patient that's coming in for episodes. What are our differentials? We sort of talked about some of them last session.
Paroxysmal dyskinesia, it's one.
Yep. So let's just say movement disorders.
Yeah.
Yeah.
Syncope.
Good. What about this one? It's kind of a movement disorder.
These are the two big ones.
Yeah, so tremor disorders.
Hmm.
So like the idiopathic head tremor. And what about rare, getting more common with brachys and their sleep apnea?
Oh,
Oh, yeah, narcolepsia,
Body?
cataplexia.
Cataplexy, yeah. Narcolepsy, cataplexy complex, yeah. Good. So they're the main things that we need to sort of differentiate. And as we talked about, many of those other causes will cause brain hypoxia and a true seizure. So it's often it can be very difficult to differentiate syncope from seizure in particular. What causes seizures? That's a big question. 8 marks.
It's what causes anything that triggers the inhibitory and the excitatory neurons of the brain that triggers that
Yeah.
hyperexcitable state.
Hyperexcitable, did you say?
Yeah.
Yes. Exactly right. So if you've got a constant balance between inhibitory neurotransmitters and excitatory neurotransmitters and the effects that they have on the cells, so it might not be a neurotransmitter problem, it might be that cell's got way too many chloride channels or something like that. But if you've got a shift in the balance away from inhibitory and towards excitatory state, then you're going to get seizure activity or increased neuron activity, which will then progress to seizure activity. So that's the sort of overall, just there's obviously so much more detail we could go into. What might a seizure look like if you're trying to recognize it? Obviously, we've got grand mal, tonic-clonic, full generalized seizures. What other manifestations might there be? Particularly in cats. We don't talk about
Focal
cats.
seizures.
Sorry.
Cats can get focal seizures.
Yes. Much
Cats
more
also get, very specific to cats, audiogenic reflexive seizures.
audiogenic reflex seizures.
Yeah.
Oh,
Cats.
cool. Yeah, in response to sound.
Yeah.
And what sort of seizures are they?
What sort of?
What do they look like?
Oh, they can like have a full generalized, but in response to a sound. Or it can be just focal.
Yeah.
I think both is possible.
If a cat's having a focal seizure, so in a dog, for context, the most common focal seizure is one hind leg, or one foreleg, just going up and having a spasm. In a cat, their focal seizures are a little bit different. Yes, someone's doing it.
Like they're chomping the mouth and salivating.
Yes, cats get orofacial seizures much more commonly than any other manifestation of seizures. So mouth chomping, lip licking. Sorry. Fly catching is another one in dogs. We see a little bit, less so in cats. Where am
Can I
I?
tell you one interesting case?
Yes.
This is really interesting. So they
Yeah.
recently had a case. It was like a big dog, bull Arab type thing. Seizuring, so confirmed the seizuring because it was full electronic clonic.
Yeah.
In the history, got to know that it happens every time the owner watches television. So there's a link to watching television. So the owner stopped watching television for 4 months because every time they were watching television, this dog was seizuring. So I
Yeah.
actually did some research, and there is a thing, it's a photosensitive seizure, which is recognized in humans. It's a mutation in the gene. So
Oh.
I had like not known of this only recently
Oh.
because I had this case and then looked it up.
Yeah.
So in terms of what do you do for it? I mean, it's a mutation in the gene, so you can't really do anything except give AEDs. But then, yeah, unfortunately, those people cannot watch TV when the dog is around.
That's a bit sad.
And the seizures went away without any anticonvulsants.
To be honest, not sure about that. I mean, I just started the anticonvulsants because like easier, but I like not brave enough to tell owners start watching television now that the dog's on anticonvulsants.
Tell them to stop watching television.
I bet they've tried it. I bet they've done the experiment.
It's so cool. I was very like it was such a bizarre thing. Never heard of it before, and it was so cool.
Yeah.
Does limbic epilepsy fit within the discussion?
Oh God. I don't know enough about it, Jeff, I don't think.
The reason I brought it up is I can't get my brain to connect on what's going on other than that you get salivary enlargement.
Yeah.
and they respond to, but I can't, I've seen some, but I can't remember now.
Yeah. So
Um,
that's
respond-
one, it's an interesting other manifestation of seizures is they can be quite autonomic. So you can have focal autonomic seizures where it's increased salivary production, increased stimulation of the salivary glands. You can get urination, you can get decreased bowel transit time. You can get vocalizing. I think most of us have experienced it, or it's either pre or post-ictal. Part of their seizure is vocalizing. And then there's motor ones as well that I've had one dog that would just be fast asleep, and would stand up and run flat out and would hit whatever was in front of it in the running, and then would hit the wall and hit the deck and then have a tonic-clonic seizure. But the start of the seizure every time was running. And they lived on a cliff edge. So obviously that's much higher risk, and a dog that you'd sort of look at controlling tightly rather than sort of conservatively. They may or may not be accompanied by loss of consciousness. In cats, less likely to be accompanied by loss of consciousness. Does anyone know what the disorder is in cats that results in the orofacial seizures?
I've seen it with hepatic encephalopathy in cats,
Oh, interesting.
but don't know if that's what you're talking about.
That's, I know, we should talk about the classification of seizures, like extracranial, intracranial as well. But the one that I was thinking of is intracranial. The specific epilepsy that's been reported in cats just within the last 10 years, which is actually autoimmune, similar to temporal lobe epilepsy in humans, and it impacts the potassium voltage-gated ion channels. But it's essentially an autoimmune disease that attacks the ion channels and alters the reactivity of the cells by changing the electrical balance within the cells. Specifically temporal lobe, and that causes these types of seizures, the orofacial kind of manifestation of seizures. So I'm not going to go into treatment of that, but an autoimmune etiology, you can imagine anti-epileptic drugs may not be needed long term if there's immunosuppression on board. So let's go do classification of seizures quickly as the last thing we talk about. So we've got extracranial causes. So these seizures we call them reactive seizures under the kind of classification system. We've already gone through differentials for stupor, coma. They're pretty similar for seizures, right? We don't need to go through the differentials. You can ask ChatGPT. Intracranial causes are divided out into, does anyone want to tell me?
Structural, idiopathic,
Good.
and then you also have epilepsy of unknown cause.
Yes. Yeah. Why is that?
Because we don't know. You can't
Isn't
decide.
that what idiopathic means? I really get it. So idiopathic is apparently the genetic forms, like familial epilepsies, whereas epilepsy of unknown cause are the ones that are truly idiopathic in my mind. But yeah, I'm not really sure that classification system is going to stick. What sort of structural? We know what structural brain diseases cause seizures, don't we? What's the most common one? Old dog comes in with seizures, increasing frequency. Tumor, exactly. Yeah. And what about a middle-aged female dog who comes in with pyrexia, elevated CRP, and seizures?
Probably inflammatory.
Yeah.
UO.
You know the differentials for these. We don't need to cover these.
Although there was interestingly a paper with MUO recently showing that CRP was quite low in a lot of them, which was I was surprised with, because I feel like I've seen it up a lot.
Yeah, normal low or
Kind of, no, like in the 20s, like,
okay.
so like marginally up, but not like your SRMAs where they're really high.
No.
So I've asked this question to a neurologist, and the answer I got is because with SRMA, because his vasculitis is systemic, whereas with the brain, like it's localized within the intracranial. This is why CRP is not always elevated.
Yeah.
Interesting.
And if you did CRP in the CSF, I wonder if that's a thing.
They did that in that paper as well.
Okay.
And yeah, it was not very exciting, but with SRMA, it was up.
Yeah, okay. Yeah, I'm the same. SRMA doesn't surprise me because it's a systemic inflammatory disease as opposed to the pure central.
Hmm.
All right. I think I might wrap up there and go and make some lunches quickly for the kids. Uh,
Thank you.
Thank you
next-
so much.
No worries. The next topic are tilism, halitosis, gagging, and dysphagia. So we'll do that in a fortnight. And if anyone's got any cases or questions or anything like that, bring them and we'll talk about them.
Cool.
All right. Thanks, guys.
Alrighty.
Cool.
Bye.
Thank you.
Bye.
Bye.
Bye.